Good afternoon and welcome to the City Club of Cleveland. My name is Mark Rosenberger. I am Director of Production and Special Projects at IdeaStream. I am very pleased to introduce today's program, Surviving Stroke. For the past week, IdeaStream has embarked on a multimedia examination of stroke, the fourth leading cause of death in the United States. Someone in the United States has a stroke every 40 seconds, and someone dies of a stroke every 3 to 4 minutes. Now, most people think stroke is relegated to the elderly. Now, while it is most common in people 65 and older, it can strike at any age. Our panelists will help shed light on stroke today. Dr. Antony J. Furlman, Chairman of the Department of Neurology at the Case Western Reserve University School of Medicine, and Dr. Warren R. Selman, Chairman of the Department of Neurological Surgery at the Case Western Reserve University School of Medicine, who together lead University Hospital's Neurological Institute in Cleveland, Ohio. As Dr. Furlman has referred to it, a stroke is like a heart attack of the brain. Not unlike a heart attack, which is a blockage of an artery, the most common type of stroke is blockage of a blood vessel that feeds the brain. Stroke strikes suddenly. It is painless. There are few symptoms, sudden intense headache, paralysis, speech loss, and others, and then they pass. Risk rises appreciably with high blood pressure and cholesterol, diabetes, lack of exercise, obesity, and smoking. Moderating today is my colleague at IdeaStream, Mike McIntyre, who is host of The Sound of Ideas, heard on 90.3 WCPN. He is also a columnist for The Plain Dealer and pens 2 columns, Tip Off and Laugh Tracks. IdeaStream has had many partners in this endeavor, The Plain Dealer, Net Wellness, WKYC Channel 3, and of course, the City Club of Cleveland. And now, Mike McIntyre.
Thank you, Mark. Thank you all. Nice outfit today from Mark Rosenberger as well, as he and I showed up at work today and said, "You're kidding me." I appreciate all of you for being here, and I want to just, for some bookkeeping measures, Dr. Warren Selman is immediately to my right, and Dr. Furlan is a little bit further to the right. So if you're watching on television or here in the audience, we've now identified these two really smart guys. Dr. Selman is director of the Neurological Institute, University Hospital's Neurological Institute. He's also chairman of the Department of Neurosurgery at University Hospital's Case Medical Center, and as Mark mentioned, also a professor of neurological surgery as well. And Dr. Antony Furlman of University Hospitals is co-director of the Neurological Institute and chairman of neurology there. So we'll find out throughout this program today the difference between neurosurgery and neurology. In fact, we can find that out now. I asked you that a little bit earlier. Dr. Furlan, you tell him where to cut, right?
That's right.
That's basically the job.
That's right.
So we're here to talk about a very important topic today, which is stroke. And the Sound of Ideas, the show that I'm privileged to host, addressed this yesterday as well. A lot of incredible reaction to it. It's information that really needs to get out there, and I want to say thank you to both of you for being here. Let's start with what is happening to us during a stroke. When someone's having a stroke, what's happening to them? Dr. Selman, can you begin?
Well, the main thing that happens is something is going wrong in the brain. The brain is the one critical organ in the body that really needs a constant supply of blood and oxygen. And essentially what happens is it's not getting that supply. It doesn't have any reserves. And so essentially a part of the brain is starting to die.
And the cause for that, Dr. Furlan, there are a couple. One of which is called an ischemic stroke. That's a blockage of some sort. How prevalent is that? And then what's the other type of stroke?
Well, about 80% of strokes are blockage strokes, where an artery that's carrying blood to the brain gets blocked with clot. About 20% of strokes are leak strokes, where an artery in the brain or around the brain ruptures. So the majority of strokes are blockage strokes, which is similar to a heart attack, but about 20% are caused by bleeding into or around the brain.
And the blockage stroke, does that lead to the bleeder stroke? Is there a combination of the two in many of the patients that you see?
While some patients can have both bleeding and blockage strokes, because the common denominator for a lot of strokes is hardening of the arteries, atherosclerosis. Another common denominator is heart disease. So the vast majority of strokes are either related to hardening of the arteries, atherosclerosis, or to a heart condition such as atrial fibrillation. And then all the other causes of stroke are relatively uncommon.
the ones that are bleeder strokes, the hemorrhagic strokes, is there anything that you can point to as a reason that those occur? Because we'll get into some of the stroke risk factors for the ischemic stroke, for the blockage, which I think we all know it's the same for heart disease and other issues. But what about for those bleeder strokes? Is there Dr. Selman, is there a particular risk factor for that?
Right, there is, and you'll hear over again we talk about hypertension as being a risk factor for stroke, and certainly one of the most common reasons that people get the bleeding type of stroke is one of the tiny small vessels inside the brain leak because they've been chronically damaged by hypertension. But there are also two other types, and one is what's called an aneurysm, which is like a little blister or a balloon on the side wall of a vessel, and a third type can be what's called a malformation, that is an abnormal tangle of blood vessels. And again, although relatively uncommon compared to the more clogging type or ischemic type of stroke, these are nonetheless very deadly types of stroke.
Dr. Furlan?
Another common cause of bleeding into the brain or an intracerebral hemorrhage is an age-related degeneration of the blood vessels called amyloid, which you may have also heard of in the context of Alzheimer's disease and memory loss. So this underlying blood vessel pathology is linked not only to bleeding in the brain and strokes, but sometimes to memory loss as a sign of disease of the blood vessels in the brain.
So you can have some sense throughout your life or something that's happened to you in the last few months that perhaps you're losing it a little bit. If you're having memory issues or there are other episodes that you've endured that perhaps you're at risk of a stroke. Is that something you should be paying attention to?
Well, it is true that Alzheimer's disease is the #1 cause of memory loss in the population, but the #2 cause is so-called vascular dementia, vascular disease. And they often coexist because it's an age-related phenomenon to some extent. So that's, as you get older, you're certainly at increased risk. The other way you can know if you're at increased risk are your risk factors. Now, these don't make you feel sick, so the important thing is you need to work with your physician to even know if you have these risk factors. You don't know you have high blood pressure until you have your stroke or your heart attack. The other common risk factors are diabetes, obesity, cigarette smoking. These are the common risk factors between heart attack and stroke. That's the risk. If you leave these untreated, you'll end up having a heart attack or a stroke.
And what about treatment, Dr. Selman, if someone does have diabetes, high blood pressure, obesity, if they address those issues, how much does the risk come down?
Well, it can markedly reduce your risk of a stroke. And again, we can't overemphasize enough. Many people think, well, I can tell my blood pressure is under control because I'm not having a headache today. You really can't do that. It requires constant monitoring. The same with diabetes. So it is very important to manage the risk factors that you can manage because some you can't.
Well, blood pressure is called the silent killer for that reason. You don't want to find out you have high blood pressure when you're in the hospital paralyzed from a stroke.
And if you were listening to the list that you just rattled off and that Mark Rosenberger said earlier, and you said, well, I don't smoke, that's really not enough. If you have all of these other factors, it certainly is an issue. And I wonder if the concern grows when the factors get combined. If you have one of them, do you worry? Or at what point does it become a higher stroke risk? If you have obesity and hypertension, or diabetes and obesity, or is it just one of those is enough to put you in that gray area?
Oh, no, the risk is additive. So the more risk factors you have, and we should also throw in family history. So if you have a family history of heart attack or stroke, especially at younger individuals in their 40s or 50s, that is also a risk factor. So the more risk factors you have, the higher your risk. And it's compounded as you get older as well.
What about stress? Is that also a risk factor?
Well, stress is a risk factor in the sense that it can contribute to other problems that we've talked about. It may have an effect on your hypertension, but stress alone per se is not going to cause a stroke. But again, it's something that should be modified, and that it can release a set of hormones in the body that can damage the arteries. So you want to make sure you are able to deal with stress in a more effective way than, let's say, cigarette smoking.
Dr. Furman?
The bigger message with stress is after you have your stroke, because it's unbelievably stressful, not only for the patient who suffered the event, but the entire family is put under stress, because oftentimes the stroke strikes an individual in their productive years. It's very common. We'll have a patient we see that was literally working that morning, and boom, suddenly they can't talk, suddenly they're paralyzed, and if they don't get to the hospital in time for treatment, that's going to be a permanent condition. So depression and stress is a major complication of having a stroke, as a matter of fact.
That's post-stroke complication.
Yes, right.
We'll talk a little bit about that kind of treatment, but let's first explain what it is we're looking for when someone is showing signs or symptoms of a stroke, because it's important not only in our own selves, but to notice it in someone else. And in fact, when we did a show on this, on The Sound of Ideas, we had an email that came in this morning from a young man who said, listen to the show, an hour later I was in my college class, and a professor started showing symptoms of a stroke in the middle of class. And he had some information from that show, which was essentially call 911, which is the immediate thing that you have to do. What are the signs, though, that he saw and that we all should be looking for? Dr. Furlan, why don't you go ahead and start?
Well, the first point I'll make is that the public is much less aware of the warning symptoms and signs of stroke than they are of heart attack, because heart attack causes crushing chest pain, can't breathe. Strokes don't cause pain, for one thing, and in fact, if it's in a certain part of the brain, you may even deny you're paralyzed because of the area of the brain that's affected. But having said that, the hallmark of a stroke is a sudden event. I mean, boom, you're sitting and all of a sudden, two things could happen. If it's a bleeding stroke, you get a violent headache. Like a patient will say, literally, a bomb went off in my head. That's a common description. Then the other way it will present is a sudden loss of function. So, going blind, suddenly can't talk, suddenly an arm just goes limp at your side. Those would be the hallmarks, the sudden onset of a neurological deficit. Now, the problem with this is many patients, as Warren knows, many patients will say, well, gee, maybe I'll shake this off. Or commonly they'll say, I'll sleep this off. I'll see if it's still there in the morning. Unfortunately, it usually is. So, I mean, if that happens, you need to get to the hospital quick. And by quick, we mean within 3 hours quick. So, I mean, like really quick, you have to get to the hospital.
And in fact, the acronym, Dr. Selman, that I've seen that people should remember is FAST, FAST. And it reminds you that you have to do things quickly. You need to move fast. Face, arms, speech, and time.
Exactly, and I would really emphasize what Dr. Furlan had said before. It is surprising how many people don't know the warning signs of stroke, and that's why we tried to make it simple in that sense. But again, if you think about it, many people will have a sudden numbness or a sudden loss of ability to use one part of their body or not be able to speak properly, and the hallmark of what's called a TIA, or a transient ischemic attack, a warning sign of a stroke, or a mini-stroke, all these names mean the same thing, but is that it goes away within just a few minutes. And so that's where people become really falsely comforted and don't seek medical attention. The fact that it went away is not important. The fact that it happened at all is important, and you still need to seek medical attention immediately for that. We always say consult your doctor for treatment of hypertension, for diabetes. In this case, you don't want to call your family physician or your local doctor because they can't do what's necessary. You really need to call 911 or get your loved one to an emergency room. That is the key message.
Dr. Furlan, what's happening in your brain if you have one of these TIAs or mini strokes or warning sign strokes? Why does it resolve itself? And many people would then just say, well, it was just a spell and it won't come back.
That's right. First, let me reemphasize what Warren just said. Don't call your doctor. A lot of patients say, well, I'm going to call my doctor. And there have been some very interesting national studies of this. The treatments we give for stroke are certainly within 3 hours, maybe 6 hours maximum. If you try and find your doctor, these national surveys show that the average delay to hospital is about 8 to 9 hours before you even get to the hospital. So you call 911. So what's happening with a temporary event, and by the way, most patients don't get a warning, unfortunately. The warning is your family history and your risk factors. You don't have the luxury of a TIA. Only about 20% of strokes have this TIA warning. But what happens with a temporary event is a piece of clot or plaque breaks off from somewhere, usually the heart or the carotid artery, goes to an artery in the brain, obstructs the artery temporarily, and then the body breaks up the clot. Its own clot-dissolving system breaks up the clot, and literally the patient 1 minute is paralyzed, can't talk, and the next minute they're fine, just literally like that. And that's deceptive, as Dr. Selman said. The patient will say, oh, there's nothing. Or, you know, oh, well, I better call my doctor tomorrow. And even some physicians, if a patient calls with that story, they'll say, well, I'll see you in the office next week. You know, they may say, take an aspirin and I'll see you next week. That's an emergency. I mean, if you have an event like that, you need to be seen immediately. You need to go to the emergency room, and typically we'll admit that type of patient for investigations.
If I'm not currently having a stroke and I call 911 because something has happened and resolved, what can you do for me at the hospital? Dr. Selman, well, you're a surgeon. That's the end result. But what kind of treatment would be offered if I had a TIA and I come in shortly after that?
Well, the first thing, so if you're totally normal when you come in, you may not need treatment at all, but the important point then is to prevent something from happening. Again, you've been given nature's really kindest warning sign. When we said initially that brain cells die, they don't always die. They can become stunned or paralyzed, and that's really what Dr. Furlan and I are talking about. So even if you come in and you're normal at that point, what we will do is initiate a workup so that we can figure out what caused that TIA, because that is the important thing. Once you know what caused it, where the blockage is or what might have broken off, whether it's in your heart or the blood vessels in your neck, we're able to discover that through very sophisticated, easy-to-be-done imaging techniques, and then we can institute treatment that will prevent the permanent stroke.
Dr. Furlan?
And the prevention really revolves around 2 or 3 strategies. The first is treat all risk factors, high blood pressure, diabetes, cholesterol. Then we will use, in many patients, a blood thinner. And the most commonly used blood thinner these days is aspirin, good old aspirin. It's an effective preventer of stroke and heart attack. We sometimes use another drug you may have heard of, warfarin. That actually is a rat poison, as a matter of fact.
Great.
But it was discovered at the University of Wisconsin. That's what the W stands for. When the cows in the pastures in Wisconsin ate clover, and it contained the active substance, and all the cows bled to death. But anyway, we use this to treat stroke, and usually in patients with atrial fibrillation, right, a heart cause. And then the other is to fix an artery that's blocked, and that's where Dr. Selman's team comes in. So if we find that that 5-minute paralysis was due to a 90% blockage in your carotid artery, then Dr. Selman's team comes and they remove the blockage. That's called an endarterectomy. So those are the main strategies we have to prevent stroke, which is a little different than when you're actually in the throes of an active stroke.
So you asked before what differentiates a neurologist from a neurosurgeon, and there I will just remind you that Dr. Furlan uses such wonderful things as rat poison, not to be outdone, snake venom, and bat spit. So that is what he uses to treat a stroke.
It works.
Great. Hey, whatever works, right? The strategy, though, of thinning the blood is one that you would use only in the event of an ischemic stroke, of a blockage. It would be the exact wrong thing to do, wouldn't it, for a stroke that occurs because of a bleed?
Well, yes, that's a good point. So, and Dr. Selman can speak to this. With a bleed, especially from an aneurysm around the brain, that's often a surgical emergency. If there's a clot in the brain, we often manage those patients medically, but sometimes surgically. For blockage strokes, the most common type of stroke, we will use clot-busting type of agents, not blood thinners per se, but clot-busting agents, which we can talk about. And then sometimes we'll use procedures, techniques called interventional techniques, where we'll take the clot out of the artery.
And let's move into that topic. We have talked about the risk factors and then how to notice that somebody is having a stroke. And we should reiterate, you call 911. And not only do you not try to find your doctor, but you also don't call your cousin or your friend or your brother and explain it. And a lot of times I think people do have a concern. They're underinsured or not insured. They're worried that they're going to be brought to the hospital and have a bill to pay when it was really nothing. And so if you wait so long to find out it is something, you might have waited too long.
Well, we haven't talked about the cost of stroke. I mean, it's over $70 billion a year in direct and indirect costs. It's a huge expense. So this kind of thinking, I mean, we see patients every week who don't take their medicine because, well, I ran out and it's too expensive. Of course, if you have a stroke, it's going to be much more expensive for many different perspectives. So that's part of our education theme. Yes, we know medicine's expensive. We'll put you on the least expensive medication we can. But believe me, if you have that stroke and you lose your job, that's going to be a lot more expensive.
Dr. Selman?
And another thing that we've talked about in the beginning is that while stroke may be only the 3rd leading cause of death, it is the #1 leading cause of loss of independence for adults. And I know many people who would say, look, I would rather be dead than really be caged inside my own body, not able to speak to my loved ones, or lose really my total independence. So although you may come into the hospital and may sustain a bill, really what you're talking about is allowing yourself to continue with your normal life, and that truly is priceless.
So we call 911. We've done the right thing. We've listened to this program. We have the symptoms. 911 is called. What is the current protocol, and how much more advanced is it today than it was even a decade or so ago. Dr. Selman?
Well, let me start, and I'll let Tony talk more about the medical therapy. But the number one difference, we brought up heart attack a lot before. One thing that is different, as you noticed, is that there's two types of stroke, the bleeding type and the clog or the ischemic type. And so that's why the hospital is the first stop, because we have to get what's called a CAT scan to find out exactly and immediately whether we're talking about a bleeding stroke or an ischemic stroke, one that is a clogged artery. Once we get to that point, we all come together as a team. You'll see we sort of talk independently here, but really it is the team of neurology and neurosurgery that really all comes together right at the emergency department with the physicians there to figure that point out immediately, and that's when the branch point starts.
You bring the knife, he brings the rat poison.
Exactly.
Well, and then there's a third member of the team who brings the catheter, because now we treat many strokes with catheters, which I'll talk about. So interventionalists, which can be surgeons, neurologists, or radiologists, are a big part of the stroke team. But it all really begins with getting the patient to the hospital on time. So up front, I mean, we can have all these fancy treatments, but if the patient doesn't get to the hospital on time, we can't use the treatments. So we talk about the stroke chain of recovery, and the weakest link in the chain, frankly, is patient recognition and getting to the hospital on time. And I mentioned before, by on time, the only FDA-approved treatment for stroke is intravenous TPA, a clot-busting drug. Now, that has to be given within 3 hours of stroke onset. I say it's a great treatment if you have your stroke in the emergency room parking lot. Because, I mean, patients cannot get to the hospital. It's just physically difficult. So that conventional FDA-approved treatment, only about 5%. Only about 5% of stroke patients get that treatment. That means 95% don't get it. And the number one reason is late arrival to the hospital. So Cleveland, this is Cleveland. You should know Cleveland's been a national model for improving the use of these types of therapies, and it's required integrating care. We call this a systems approach to care. But it means when a patient calls the hospital, our transfer center sends a helicopter literally to the patient's yard. Okay? We've done this, picked up patients in their backyard with the helicopter. All right? This puts the system in gear. They take the patient to the hospital, the patient's stabilized. We're getting pictures immediately. Is this a hemorrhage? Is this a bleeding stroke or not? If it's not a bleeding stroke, then the next question is, can we open the artery? Do we have enough time to open the artery? And the question, and that's time-driven to some extent, although now we have new techniques that tell us if the brain is alive or dead regardless of the time. That's some of the research that's going on here in Cleveland, as a matter of fact. But really, you have to think within a 3 to 6 hour time frame. And then the next question is, well, how are we going to get the artery open? And we really have two options. One is the FDA-approved drug in the vein, drip the drug in the vein, TPA, open the artery, and some patients qualify for that. But if you have a really bad stroke, then you're going to need the catheter approach. And that must be done downtown. So we have many stroke centers in Cleveland. Many of our community hospitals can do the intravenous therapy. But only 2 or 3 hospitals in town can do the catheter therapy. So then we have to get the patient from the community downtown. So we've got the helicopter in the air a lot here, you see. And this is all, mind you, within 6 hours. So then when they come for the catheter, then we can literally fish the catheter up into the head, and we can literally suck the clot out of the artery. Now, if we can do all that within 6 hours, there's about a 40 to 50% chance of a better recovery than if the patient doesn't get that kind of treatment. So it's had a huge impact, but as I'm describing, I mean, this it's a tour de force of system integration. If any of these chains is weak, then we lose our 6 hours. So, I mean, it really has to click. And we, fortunately, in Cleveland, are blessed with some of the best stroke systems in the country, as a matter of fact.
And Dr. Selman, you would be doing the catheterization of those types of things, or do you help in that? Is it guided through imaging equipment?
It's guided through imaging. It's actually done by people who are called neuroendovascular specialists. And as Dr. Furlan mentioned, there's a whole variety of people who do that, but they're either neuroradiologists, neurosurgeons, or neurologists.
And the combination of TPA and this catheter treatment, does that improve outcomes? That if you're at a tertiary hospital and you receive the TPA, that gives you a little leg up as you're moved into this more specialty.
Well, that's an excellent question, and it shows you how the field has changed. So I should point out to the audience that the FDA approved TPA in 1996. So this is a relatively recent development in stroke care. Before 1996, none of this took place, right? So, and the first approach was sort of an either-or. Either you give the drug in the vein or you use the catheter. Now the trend is to combine all of these tools in our stroke toolkit. So what typically happens, and we've been pioneers in the concept of drip and ship. So the patients out in Geauga County, say, and they go to the local community hospital, well, the TPA starts the drip. They're put in the helicopter, and they're shipped down to the cath lab downtown, where we take the patient. We probably do another scan to see where we are with the stroke, but then they're whisked right to the angio suite, and the catheter is inserted, and then the clot's pulled out. So we combine, and that's called drip and ship. So we combine intravenous and intraarterial approaches. Again, all with, to me, it's still miraculous. I've been doing this for 30 years, and it's still mind-boggling we can do this within 6 hours. Okay.
Being somebody who's done it for 30 years, and I'm sure that you've been in the surgical field for a long time as well.
Certainly not quite as long.
Not quite as long as 30 years. I wonder what the change, what a seismic change there has been in the standard of care. You were mentioning before 1996, you didn't have TPA.
That's right.
And some of these other strategies. You pulled the curtain and sort of let it run its course?
Well, before 1996, there was no evidence-based treatment for stroke. We often used a blood thinner called heparin, but there was really no firm evidence. In fact, now we never use heparin. I mean, it's amazing. Before 1996, that's what everyone used was heparin. Now we almost never use it in any patient. So it's been a paradigm shift in how we approach. And I say we've become plumbers, stroke plumbers. I mean, the concept even, I participated in many research studies where we would treat a stroke patient at 48 hours, 72 hours. We thought we had time. And then it dawned on us suddenly that no, time is brain. We have 3 hours. We don't have 3 days. We have to do all of these things. And then you can imagine the system was not ready for this. I mean, we had a very casual approach, really, to stroke when a patient would come in the emergency room. And that's radically changed over the last 10 or 15 years.
Let's talk a little bit about the after effect of stroke. So you've come and you've had the treatment, but stroke has damaged your brain. You mentioned it's the leading cause of disability in this country. Some people are more disabled than others. Why is that? Why does stroke strike differently? And what about rehabilitation measures to bring people back to function?
So there are two questions there, and we'll take each one. The first is, why does it happen, and why do different people react differently? It really depends on what area of the brain is affected. And some can be in an area where it affects your arm, or some can be where it affects the leg or your speech or your understanding. So the manifestations can vary depending upon what area of the brain is damaged. And although we've thought in the past that brains simply don't recover, that's not true. We've learned quite a lot, and part of the work was actually done here and continues to be done here at Case Western Reserve University and at university hospitals, and that we know that we can sort of retrain the brain to do things by something as simple as, let's say, instead of trying to make the person use not the good arm, that we just sort of hold the good arm paralyzed, strapped to the person and say, you must use that paralyzed arm. And in fact, the person learns to do that. So there is a remarkable amount of recovery that can happen when we're utilizing that. You'll see that we're also partnering with the School of Engineering to figure out ways to actually make paralyzed limbs work again through interfaces with computer. It's called the biodigital interface and neural engineering. So a lot going on, and as Tony mentioned, what we really call it is the chain of recovery. And everywhere along that chain that we can interact, we try to return patients to their normal lives.
And how does it affect people differently was the other part of the multi-pronged question that I threw at you. The idea that some people are more damaged than others. Is it just the severity of the stroke? Or?
Well, there is a severity of stroke. There's a grading scale called the NIH stroke scale. Certainly if you come in with a higher grade stroke, you're less likely to recover initially. But also, again, it depends on the circulation in the brain. Sometimes the cells are just stunned and they tend to recover. So a lot of things can happen to repair the brain, and we are working very hard on ways of things called neuroprotectants that we can try to still protect the brain while it's just sort sort of paralyzed rather than totally damaged. And again, all these factors come in to determine what an individual will experience with the stroke.
And Dr. Furlan, what about the brain's plasticity and the idea that repetition can maybe build different pathways and give you function back, even in places maybe right next to the place that has been damaged by the stroke?
Well, one of the interesting things about stroke is that patients do improve. And one of the mysteries of stroke is, why do they improve? It's still not fully understood, although new studies like PET scanning and other studies are telling us that other parts of the brain can take over for the damaged area of the brain. Some of the cells aren't totally dead in the area of the stroke and can recover. So we are looking for strategies to promote what we now call brain regeneration. And this is, we talk about rehabilitation, now we tend to talk more about regenerative techniques. Warren mentioned some, brain-computer interface. There's stem cell. There's a company right here in Cleveland, Athersys, that's at the forefront of stem cell therapeutics for stroke regeneration. But those are in the future. I mean, most of stroke rehab is hard work. I mean, these are cutting-edge concepts. But the fact is, we focus on things we take for granted, called activities of daily living. So if suddenly you're a 60-year-old individual who has to learn to walk again, or you're a 60-year-old individual who has to learn how to go up steps or feed yourself. I mean, this is very difficult. And the older you are, the harder it is to recover, obviously. So we have to start those treatments immediately. And then the other sort of hidden, I alluded to earlier, the other hidden aspect of stroke are the cognitive aspects of stroke. Change in personality, change in behavior, severe depression. Depression is a big problem for stroke patients. So these are all the things we have to tackle. And I tell you, these things are exciting, catheters and that, but I say this is a failure of medical care. I mean, we don't want to have to come in at 3 a.m. and pull a clot out of somebody's brain. Okay? We don't want that to happen. I mean, the big message of today's symposium is not so much all this exciting research, but prevention. How can we prevent this from happening? And it really is in patients' hands to some extent.
We'll have much more to talk about with this, but I now want to introduce Mark Rosenberger once again for some messages. The very well-dressed Mark Rosenberger. Go right ahead, Mark.
Thank you. Today at the City Club of Cleveland, we are listening to a special program, a fascinating conversation, I think you'll agree, featuring a panel discussion with Dr. Antony J. Furlan, Chairman of the Department of Neurology at the Case Western Reserve University School of Medicine, and Dr. Warren R. Selman, Chairman of the Department of Neurological Surgery at the Case Western Reserve University School of Medicine. We will return momentarily for our traditional City Club questions. We encourage you to formulate questions for our speakers now, and then remind you that your questions should be brief and to the point. We welcome all of you here, especially those who are guests. We hope you will join the City Club and become active in our ongoing civic dialogue. In 2012, the City Club of Cleveland will turn 100 years old. We are planning a number of events and will be actively soliciting support from the community through our campaign for a new century. Our celebration will begin actually on October the 10th of this year with the Conference on Free Speech at the Allen Theater. To learn more about the 100th anniversary events, visit the City Club website. That's at www.cityclub.org/100. We welcome all of you here and those listening to WCPN 90.3 FM, WCLV, WTAM, or one of the many radio stations across the country. Our television broadcasts of the City Club are made possible by Cleveland State University and PNC. Our live webcast is supported by the University of Akron, and the television broadcast partner is WVIZ PBS IdeaStream. We are pleased to welcome guests at tables hosted by the Case Western Reserve University School of Medicine, IdeaStream, and University Hospitals. Thank you for your support. Now, we'd like to return to our speakers for our traditional City Club question and answer period. We welcome questions from everyone, including guests. Holding the microphone today is the City Club Program Director, Carrie Miller. So now on to our first question, please.
Well, I don't know quite how to frame this question, but I'll try. Let's assume that I have a stroke, something I recognize as a stroke, and I am taken to the nearest emergency room by my wife or a neighbor. and I get there 2 hours after I've had these sensations. How does the emergency room triage system work? I've been to University Hospital's emergency room on the main campus on a Friday evening and have waited hours. Is the triage work in my case? And is it different if I come by EMS?
Dr. Furlan?
Well, the last question, EMS is the quickest way to the hospital. And we've worked closely with Cleveland and surrounding EMS groups to standardize stroke protocols. So actually, one of the things Cleveland's been very good at is a national model for these systems approaches. So we are all using the same protocols. All EMS uses a stroke protocol that we help them develop. So they diagnose stroke in the field, and they're right about 80% of the time, 90% of the time. So they alert the emergency room that a stroke's on the way, and that starts triggering the sequence of events that I outlined before. But if you go to pretty much any community hospital in the Cleveland region, they're going to have one of our protocols. All the hospitals have the same stroke protocol. So we're doing the same thing. And we have guidelines. When do you call downtown? When do you manage locally? Who's a patient for intravenous only? Who's a drip and ship candidate? So all of that's been worked out. So the important message is, yes, for stroke, the protocols do work. You're not going to wait, 6 hours to be seen if you have a stroke. In fact, the National Institutes of Health guidelines, which I helped develop, say you have to see a physician within 10 minutes of hitting the emergency room if you're an expected stroke. Now, how do we know that's happening? We have citywide quality improvement program that Cleveland helped pioneer in something called Operation Stroke. We developed these national standards that all hospitals in the United States now follow, and we track this in all of our community hospitals through a process called Get With the Guidelines, which is an American Stroke Association national quality program. So we know and we track all the emergency rooms in Cleveland, and are they doing their job? Are they seeing you with your stroke within 10 minutes or not? And if they're not, why not? And how can we improve that? And I'm pleased to say, if you're going to have a stroke, Cleveland's a great city to have a stroke in.
And it might be one of the reasons why if you go to an emergency room with something less serious, you'll be waiting because you guys are busy addressing stroke victims and other people higher up on the triage. Perhaps the example that you used when you went into the emergency room and waited, it obviously wasn't in that type of category.
Oh, that's correct. That's correct. Mm-hmm.
Let's take another question. Go right ahead.
Well, actually, I have two. One is the brain the only organ in the body that doesn't create new cells? I mean, are we born with a certain number of brain cells and then after that you're out of luck? You go away. And as a person who has some risk factors already, am I just like watching the clock? Or if I control my blood pressure and my type 2 diabetes, am I, okay?
Well, let's start with the first part of that question.
So we now know that the brain, in fact, does repair itself, and there are areas that can regenerate, and we're learning how to control that and modify that. So I think it was an older misconception that the brain doesn't grow new cells at all, but certainly we can do things that help it if we need to, and we're learning about that. The second question is, are you a ticking time bomb, or are you, however you wanted to place that? I mean, I think the short answer is no, but the part of that you have to own is that not only do you have to be aware of your risk factors, but you have to be willing to modify them. And it's a fortunate thing that the thing to do to modify them are very simple, and you've heard them over and over again from your doctor, no doubt. It refers to exercise and diet, and controlling your blood pressure, learning about your blood pressure, and any other risk factor you can modify. So clearly you can do things to prevent that from happening.
Thank you, Dr. Selman. And Dr. Furlan, did you want to add to that?
Let me just amplify on the risk factor question, because that's perhaps the most important question that could be asked today. You can reduce your risk of stroke by 50% by treating your risk factors, and everybody shakes their head, okay? But what happens is, even people who know they have risk factors, you don't take your medicine, or the medicine you take isn't doing the job, it's not monitored. How often do you see your doctor? You see your doctor every 6 months. So how often are you checking your blood pressure? How often is your cholesterol being checked? So it's one thing to know you have risk factors. It's another thing to be on treatment. It's another thing to make sure the treatment's working. And the unfortunate thing is national statistics show we don't do a great job with this approach to vascular disease. There are many patients who know they have risk factors, but they're not being treated or not being well treated. The most recent, and this is a moving target, by the way, how we treat risk factors. The pills change, too, over time. The most recent study that looked at stroke risk reduction, a trial called SAMPRIS, they used a life coach. So their idea of treating risk factors was they'd assign you a coach to come out and really bug you, you know? So, I mean, it depends how aggressively you want to, and how serious, you know, each individual is about their risk factors.
As long as we're talking about risk factors, what about the disparity, the racial disparity of prevalence and of risk factors as well? African Americans are twice as likely as white Americans to suffer stroke, and as they're younger, if they're very young, 4 times more likely,
Right.
and outcomes are much worse in that community as well. What about that prevalence issue?
Well, and to extend upon that, one of the interesting things about hardening the arteries, the #1 cause of stroke, in African Americans, Hispanics, and Oriental populations, the blockage tends to be in an artery up in the head itself. Whereas in white Caucasian populations, it's often outside the head in the neck. That's another one of the mysteries about hardening of the arteries. The issue of racial disparities in stroke, in the United States, the highest rate of strokes in the southeast, that's called the stroke belt. And it's been known for many years that that's a more prevalent area for stroke. Now, why is that? Partly, a lot of this has to do not so much with your race, although genetics may play a role to some extent. It has more to do with access to care and physician availability, compliance with medication. In underserved populations, things like compliance and inability to afford medication. Large percentage of uninsured patients. That's a big part of the story, unfortunately, and I think explains to a large extent these disparities we see.
Next question, please.
Thank you very much for being here today. My question is, I wanted you to respond to the type of patient you might have that doesn't have the risk factors. Not ignoring the population out there that is healthy and may have a stroke without even knowing it because they don't have high cholesterol, they don't have a family history, they don't have diabetes. That does happen from time to time. So typically, what kind of patients, if there is a patient out there that might meet that profile, that should be also listening today? And then I also, had a follow-up note with regard to gender differences possibly, as opposed to racial differences, and how symptoms might present themselves or be resolved.
Speaking of patients, the person asking the question and the voice you hear, as we learned at lunch today, is a patient of yours, Dr. Furlan. If you'd like to answer that question and maybe even tell us a little about that case as well.
Sure. Well, Gene, I'm sure you don't mind me mentioning you had where were you, at 38,000 feet when you had your stroke? And the plane landed in Kansas City and was taken to she was taken to a hospital in Kansas City and had the treatment I described. Catheter removal of a clot in an artery on the right side of her brain, and then was transferred to Cleveland. That's a real systems approach to care. And she was healthy. So actually we haven't talked about that because it's not appreciated that even infants can have strokes. Certainly young adults, healthy young adults can have stroke. It's not so rare, but the causes differ. Whereas in older populations, we're usually talking about hardening of the arteries or atrial fibrillation. In younger populations, first of all, about a third of patients have what we call cryptogenic stroke. Meaning we can do every test we know, PET scans, everything else, and we can't find where the clot came from. I mean, you can imagine our frustration. You know, we have all this fancy technology, and we strike out about a third of the time. The patients, I was afraid to go in and tell a patient, well, we just did $50,000 worth of tests, and I don't know where that clot came from. So that's actually the #1 cause, if you will, of stroke in younger individuals. When we do find a cause, it's often a congenital heart problem that you're not aware of, like a little hole in the heart called a patent foramen ovale is actually a common cause, or an injury to an artery. You may have bumped your head or something inadvertently, and the artery gets injured and tears. That's called a dissection of the artery. So yes, strokes do occur in younger individuals. So the important thing there is to know that you're having a stroke, to recognize. So, and again, just to review, suddenly you're paralyzed, suddenly you can't see, suddenly you're talking gibberish. Okay?
And if you don't know this is happening to you,
well,
you need to have other people that can see that.
That's right, and you're going to need help, because obviously if you have a stroke, you're not going to call 911 yourself in most instances, and so someone around you. That's why a stroke is a family affair. I mean, if you have risk factors, many families I have know the route to the nearest hospital. I mean, they've got it all mapped out. They're ready for a stroke or a heart attack if it happens.
Let's have Dr. Selman jump in on that as well.
So one thing that you mentioned is, let's say you're totally normal and you don't have any risk factors you know of. One thing that we haven't spoken a lot about, and that does tend to occur in a slightly younger age group, is the hemorrhage type of a stroke. And one of the very common things of that is an aneurysm. And again, we've talked about some of the warning signs, and we've mentioned the absolutely worst headache of your life. Well, certainly if you have the worst headache of your life, you're going to see somebody. The question is, what happens if you just have a headache? And a lot of times aneurysms are signaled by what's called a sentinel headache or a warning leak, where the aneurysm leaks just a little and you get a headache, but it isn't the worst headache of your life. So now I've got everybody out there thinking, my goodness, every headache, do I have to go to the emergency room?
Every hand in this room just went up to their head.
So the answer is no, but you do need to remember that that is a warning sign. That's something we can screen for. And what we tend to say, if it's the first headache, the worst headache, or if you're cursed, that is, cursed with a neurological deficit, if you have a headache and your arm doesn't move, you do need to seek medical attention, because we can find the problem before it's a disaster and treat it by very sophisticated techniques, whether it's microsurgery or using a catheter. But we do have the ability to prevent that in patients who really do get a mild warning sign.
And the second part of our question was about gender disparities.
Well, there's been a lot of publicity about missed heart attacks in women recently in the media, but there's been less publicity about missed strokes in women. Stroke in women, there are some special circumstances. For example, the whole question of hormone replacement therapy. I mean, we went through a phase 10, 15 years ago where we told women that estrogen was a preventative for vascular disease. We now know through the Women's Health Study it's just the opposite. It leads to heart attacks and strokes. So certainly we caution women with risk factors not to use hormone replacement therapy, for example. The whole birth control pill, speaking of different causes of stroke, birth control pills, that's a very controversial topic. It probably does increase a woman's risk of stroke, especially if you smoke, for example, have high blood pressure, and are on birth control pills. So these are additive sorts of effects. And then certain strokes, I mean, stroke is more prevalent in men in general, largely because of their lifestyle changes and bad habits, smoking, for example, up until about the age of 65 or 70, and then women start to take over. And then for certain types of strokes, Warren mentioned aneurysms. They're slightly more prevalent in women, as a matter of fact. So there are some sex-based differences as well.
Next question, please.
Hi. I'm one of the aneurysm survivors. I had no headache. I was just out, and I was out for, I don't know, maybe a month, close to that. But my question is, it happened to me, it'll be 6 years ago, October 30th. I was taken to the local hospital, flown to Metro, and then flown to you, that man right there. And I don't know what all happened to me. I've got 4 titanium screws right here, and I'm told that the next day you did an angiogram. That would be the 31st, and then I didn't have the surgery until Wednesday, November 1st. How was that delayed? Why didn't I just bleed to death? What did you do? And I'm supposed to have a clip in here somewhere.
Well, so a lot of times we don't do surgery immediately because we need to stabilize something. So you're probably given a drug that actually helps form a barrier around that aneurysm so that it doesn't bleed again while we do what we need to do to make sure everything else is just perfect to go through surgery. Sometimes there's some swelling and things like that where, so another difference between a neurologist and a neurosurgeon is Tony rarely ever does anything that will cause a stroke. Sometimes I do things that can, and so we want to minimize that chance of doing that and make sure you have the best outcome.
And Dr. Selman, this patient is not going to be charged for that consultation, is she?
Absolutely not.
Clip. She was asking about a clip, and what exactly does a clip do? And
So a clip is just what it sounds like. It's like a little spring-loaded clip. It's very tiny, only a few millimeters long. It's made out of pure titanium. And what we do is we do what's called microsurgery. So that's one of the things that a neurosurgeon is able to do. We're able to make a little window in the skull and go directly between what really is sort of nature's way of giving us access to the blood vessels in the brain. We don't actually go into the brain itself, but there's little corridors that we can work in under the microscope. We see the area that's abnormal and it looks like this, and we put a clip right across it so that blood can no longer enter that aneurysm, but still go on to supply your normal brain.
as usual, terrific questions here. Let's take another.
So TPA's been in the clinic since 1996. Could you discuss new therapies that are on the horizon for treating patients that have had a stroke?
Well, let me take a
Dr. Selman,
stab at that first, because I was going to mention. So you said that, that one of the differences, or I said, is that we can actually cause a stroke. So neurosurgery sometimes, or operating on an aneurysm or a vascular malformation, has been described as trying to fix an automobile engine while it's still running. So one of the things we have to do is stop the blood flow initially to that area so that we don't have any more problems. But in putting those clips on to temporarily stop the blood flow, it's just what Tony was talking about before. We're essentially clogging the arteries. So it's very important to us to be able to provide something that will allow the brain cells to survive when we do that. I'm very fortunate to work at Case Western Reserve University because I can partner with wonderful people, one of who's sitting in the audience, Dr. Allison Hall. And Dr. Hall is a neuroscientist who just so happens works on ways to keep cells alive when they don't have blood flow. So one of the things that I use are neuroprotectants, and we've worked together to try to extend that, because the obvious question is, Dr. Furlan keeps talking about this 3-hour time window or 6-hour time window, and we have to find out whether or not it's a bleeding stroke or an ischemic stroke before we can provide TPA. What if we had a drug like a neuroprotectant that we could give right out in the field that would take that window and suddenly make it 12, 16, or 24 hours? And I think that's where the great emphasis is going to be. Can we use neuroprotectants, antioxidants, any number of things that you may have heard of, to allow us to open up that therapeutic window? And I think that's where we're heading, and it's a collaboration with the neuroscientists that allow us to do that type of translational research that will transfer to the clinics.
Dr. Furlan?
So one of the more promising neuroprotectants, and the idea here is to keep that window open so the window doesn't close. So that means treatment in the field. So we were asked before, what does EMS do? Well, it would be great. Usually we waste 1 to 2 hours just getting the patient to the hospital in the ambulance. So why not start something in the field? So one of the more promising neuroprotectants, for example, is hypothermia, lowering body temperature. And it used to be, this was very cumbersome with literally ice and alcohol rubs. Now there are devices, cooling collars around the carotid arteries, a Vicks VapoRub type substance you put in the nose that cools the brain. And the idea would be to start this in the ambulance while the patient's on the way to the hospital. The temperature, you've all heard of children especially falling in the icy lake and being revived hours later. Well, it's the same idea. You shut the brain's metabolism down and you keep that window open so you have time to access the catheters and the clot busters. And then in terms of clot busting therapy, I mean, it was mentioned earlier, I'll tell the audience, so the last drug we worked with was in fact vampire bat saliva. Okay? So the drug...
You're making this stuff up now, aren't you?
If you think about it, Mother Nature often gives us treatments, right? So a scientist asked, an Australian scientist asked one day, well, why doesn't the blood clot when a vampire bites somebody in the neck? And they isolated the substance from the bat's saliva. Bat spit always sounds better. And then we worked with it, but we also used and we used it out to 9 hours. Okay, so we were able to get out in the research study out to 9 hours, and we used different types of brain scans, a special type of MRI scan, which tells us, I call it an EKG of stroke. It tells us if the brain's still living or it's dead, and it's just dangerous to give these clot busters. So this is the way the field is moving. First of all, keep the window open with a neuroprotective strategy. To do the right brain scan that says, well, the brain's still alive, but you better, you have X amount of time to keep it alive, and then combine different types of therapies, intravenous, intraarterial catheters, do all of this in a timely fashion.
Dr. Warren Selman and Dr. Antony Furlman, I want to thank both of you for being here for the great education today. It really has been an awesome discussion. I appreciate you being here. And Mark Rosenberger has a message to close out our program now.
Thank you. Today at the City Club, we've been listening to a panel discussion featuring Dr. Antony J. Furlan, Chairman of the Department of Neurology at the Case Western Reserve University School of Medicine, and Dr. Warren R. Selman, Chairman of the Department of Neurological Surgery at the Case Western Reserve University School of Medicine. Thank you, panelists, and thank you, ladies and gentlemen. This program is now adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.